Hello friends, today our topic of discussion is going to be ITP, newly diagnosed ITP. And before I go into the lecture, I would like to thank Dr. Raghuram, hematologist from Bangalore working in Aster and Rainbow Children's Hospital, for helping me shape the management part of ITP. Thank you, sir. So onwards with this topic. So this is a question that has been asked multiple times, and this is a case that we see multiple times in our practice, isn't it so? So these are the topics under which I'll be discussing. So we'll see what it is about, how is it classified, and why is the classification important, the pathophysiology, manifestation, investigation, management, complication, and prognosis. I think this is the outline in which you should be able to write an answer also if a question is asked. So ITP. So there are multiple ways in which this is defined or expanded, I should say rather. Idiopathic thrombocytopenic purpura. Idiopathic is generally told as we are idiotic and patient is pathetic, or the other way around. So that is one definition. The other one is immune thrombocytopenic purpura, which lets us know that this is an immune process that causes the thrombocytopenia. And the third one is immune thrombocytopenia. The third one might be more apt because it says that it is an immune process. It says there is thrombocytopenia. And as to the manifestation, these two says purpura, but sometimes patient can present without purpura with just mucosal bleeding. Purpura means a dry bleed, isn't it? So a skin bleed is generally called a purpura, right? And ITP, so whichever way you want, you can call it. All right. All are right. There's no wrong in this. Most common cause of acute onset thrombocytopenia in a well child, in a previously well child, is idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura. So for the purpose of discussion, we'll just keep it as ITP. Okay, so let's not fight over which expansion is right. So the most common age group that you can see is 1 to 4 years, and there can be a smaller peak in the adolescent age group. The earlier peak is in the 1 to 4 or 1 to 5 years age group. In childhood, it equally affects male and female. It does not discriminate, but in adolescent age group, females are more affected to males. And incidence ranges somewhere in 1 in 20,000 children. So there are multiple ways in which ITP is classified. One depends on the duration. Okay. So one is new onset ITP, which is less than 3 months following a diagnosis of ITP. Second one is persistent, which is 3 to 12 months from the initial diagnosis. Chronic is more than 12 months. 20% of acute ITP patients end up as chronic ITP. So if you see this classification that is given in American Society of Hematology 2019 does not talk about acute ITP. It is just that you have diagnosed a child with thrombocytopenia, a previously well child. Correct? You don't know if the ITP is acute or persistent or chronic. Correct? So at the point of diagnosis, you will not know. You have just diagnosed an ITP and you are assuming that it is new onset. If it is going to persist beyond 3 months, you call it as persistent. If it is beyond 12 months, it is chronic. Next one is dependent on severity. Why this severity classification? Severity classification is for us to know, yes, of course, severity, and next to plan on your management. Okay. Grade 1 is minor or minimal. Few petite, less than or equal to 100 total, and or less than 5 small bruises which are less than 3 centimeters in diameter. Grade 2 is mild, where there are more petite, more than 100, and more than 5 large bruises which are more than 3 centimeters in diameter. Grade 3 or moderate is mucosal bleed. Mucosal bleed is wet purpura. Skin bleed is dry purpura. All right. Mucosal bleed, but it is not severe enough to warrant medical attention, like a small duration of, brief duration of epistaxis, less than 10-15 minutes. It does not require anything. Intermittent gum bleeding, menorrhagia. But these do not affect any lifestyle activities. Grade 4 can be severe or life-threatening. Okay. So severe is similar to grade 3 but more severe. That's all. As simple as that. Mucosal bleed or any hemorrhage that requires medical attention. Any severe GI bleed, any prolonged epistaxis, pulmonary hemorrhage, whatever it can be. Any bleed that is severe or more in quantity that requires medical attention is severe. And if the same bleed occurs in intracranial or in large amount, then it is life-threatening. Okay. So this is to grade the severity and for us to narrow down the management. Next, based upon etiology. This etiological classification is again important because if you know the cause of thrombocytopenia, you may be able to manage it appropriately by treating the underlying cause. Primary is what we see mostly in young children. Secondary, in older children, it is possible. Drug-induced. What is the common cause of thrombocytopenia that you know is drug-induced? Heparin-induced thrombocytopenia in hospital settings, especially if you are using for a long time. Systemic illness, especially systemic lupus erythematosus, SLE. Infection, HIV, very, very important for chronic ITP especially. Immune deficiency and vaccination. Vaccination, childhood vaccination, MMR is associated. 6 weeks post-vaccination, child may go on to have a ITP. Know this point. So now that you know the classification, why does this ITP happen? I am going to talk about the primary ITP. Does not have any underlying disorder per se. Usually it starts with a viral infection, most commonly a upper respiratory tract infection. 1 to 4 weeks later, the child will start having purpura. Okay. And this usually you diagnose as acute ITP. So why does this viral infection cause a thrombocytopenia? Isn't it so? So viral upper respiratory infection or any infection in general can cause formation of autoantibodies. We do not know the target antigen in acute ITP or new onset ITP. Chronic ITP, these antigens alpha 2b, beta 3 and glycoprotein 1b are found as target antigens. This antibody, autoantibody which is formed, coats the platelet surface. This antibody coated platelet will be identified by splenic macrophages and they destroy. And hence you end up with a thrombocytopenia. Correct. This is the pathophysiology. So viral infection, autoantibody coats platelet, platelets get destroyed by spleen, splenic macrophages. So how will the child present? A typical presentation will be of the age group 1 to 5 years or 1 to 4 years. Previously well child went to sleep happily. Next day mother is noticing multiple purpuric rashes or bruises or some mucosal bleed, but no trauma. This will be the usual presentation, and if you ask a proper history, you may be able to elicit the history of viral infection in 50 to 60% of the children. So what are the red flags that you should consider for alternate diagnosis? What should make you think that no boss, this cannot be a immune thrombocytopenic purpura. I should be looking for something else. In history, if there are constitutional symptoms like fever, weight loss, night sweats, malignancy should be coming to your mind. If there is bone pain, again malignancy should come to your mind. Recurrent thrombocytopenia, then something else is going on. This is not just a one-time event. If the child is not responding that well, then okay, maybe something else is going on. I will have to work up the child for that. So these are the things in history that should, raise your antennas to some other diagnosis. In clinical examination, if you're finding a lymphadenopathy, hepatomegaly, splenomegaly, or the child is looking sick, signs of chronic disease are present, then you should think that maybe a chronic process like a connective tissue disorder or something like a malignancy is going on in the child, and that is what is causing this thrombocytopenia rather than a viral infection induced immune thrombocytopenic purpura. Am I clear? These red flags are very, very important for your clinical examination. All right. So now you have a previously well child who is happy coming to you with acute onset purpura, and this child is bouncing on the bed. Okay, this will be your usual clinical picture. The parents will be more anxious compared to that of the child. Child will be relatively happy. So how are you going to investigate? See, investigation, the only investigation you will need actually will be a CBC. Okay. In CBC, what are you going to expect? You expect a thrombocytopenia, obviously. Size is usually normal or increased. Increased size just reflects the increased bone marrow production of platelets. That's all, nothing else. And anemia may or may not be present. It depends on the bleed. Okay, if there is going to be significant bleed, then proportionate anemia will be present. Note that the word proportionate is very, very important. Other investigations like HIV, ANA, direct Coombs test, only if you are suspecting or they are at risk population, you are going to do these tests. Otherwise, most of the time, these are not required. Okay. So essentially, a normal CBC with thrombocytopenia is what you will be seeing for a ITP, classical case of ITP. Bone marrow investigation. So if at all you are doing a bone marrow, what are you going to see? You will look at normal or increased number of megakaryocytes, and immature megakaryocytes can be seen. Again, just reflects increased production. Okay. All other series will be normal. Your granulocytic series will be normal. Your erythrocytic series will be normal, because those are not affected by this process, isn't it? So it's just the platelets that are getting affected, and that is what will be reflected in bone marrow. So when should you be doing a bone marrow? Bone marrow you will do only if you have doubt of other differential diagnosis. Like you are having something in the history and physical examination that is suggestive of marrow failure syndrome or a malignancy. Or there is unexplained anemia, which is disproportionate to the bleed that the child has had. Or there is abnormal WBC count or a differential count that is making you suspect this can be malignancy. Then you go ahead and do a bone marrow. Bone marrow is not indicated as a routine. Please remember that. No need to do a routine bone marrow examination in a typical case of ITP. No need to do a bone marrow if the child is not responding to a single dose of IVIG. No bone marrow before you do a splenectomy or before starting steroids. Okay, these are not recommended. So in lab investigations, what should make you think of an alternate diagnosis? Again, as we already discussed, if it is a low hemoglobin, which is disproportionate to the amount of bleeding, a high MCV, this is usually found in bone marrow failure syndromes, abnormal WBC count or a neutrophil count, abnormal cellular morphology on smear. Okay, so these are the conditions in which your antennas should go up, thinking that this may not be typical case of ITP. Okay, all right. So now you have done investigations and all those. So are you sure this is primary ITP, or should you be considering secondary ITP? If you still have this doubt, you may have these three things. If it's an adolescent child who's coming to you for the first time, and thrombocytopenia is not that severe, it's just moderate and it is of insidious onset, it's not acute, then secondary cause of ITP should be at the background of your mind, okay, while managing this child. All right, so now you have got the child, you have investigated, you saw that this child has a typical case of ITP. So how are you going to proceed? How are you going to treat this child? Okay, so general instructions that you will be giving is activity restriction, avoidance of antiplatelet, anticoagulant medication, and if a female child is having menorrhagia, you may advise hormonal therapy or antifibrinolytics. Activity restriction especially is advised in less than 30,000 platelet count. Contact sports, collision sports are especially avoided, and insist on them wearing helmets, because what you are trying to prevent mainly is intracranial hemorrhage, and that is what you are worried about, isn't it so? See, even though you worry about it that much, the incidence of intracranial bleed per se in a classical case of ITP is less than 1%. It ranges somewhere around only 0.6%, 0.1 to 0.6, depending upon the study. Okay. Contact collision sports, apart from intracranial bleed, you do not want this child to have an intra-abdominal bleeding either. So because of these reasons, activity restriction is advised. So specific management. Before going into what medications, how much, when, what, all those things, some statements that I would like to drill into your minds. Those are these. See, therapy does not affect the natural history of illness. Whether or not you give treatment, this child is going to recover by 6 months. Okay, a classical case of ITP will recover by 6 months, 70 to 85% of patients. Okay, so note this point. Second one, it does not prevent severe bleeding or intracranial hemorrhage. At least evidence has not yet shown that it prevents severe bleeding or intracranial hemorrhage. Next, therapy does not affect any short or long-term clinical outcomes of ITP. Okay, you may not be able to predict how this child is going to be in the long run. Okay, so therapy does not have any effect on natural history, does not have any effect on long or short term, does not prevent severe bleeding. Then why the hell do we manage these children with medications? See, the answer to that is difficult, at least for a simpleton like me. Okay, I think hematologists will be able to answer it better. But it is mostly to, reduce anxiety, and the risk of bleeding is always there at the back of your mind, isn't it? So you want the rise in platelet to be about 20,000, a theoretically safe level, within quotes you should put it, isn't it? So more than 20,000 you want, so that you don't want ICH. That is the reason most of the patients or most of the doctors try to give medications. But what do guidelines say? There are so many medications available, isn't it so? IVIG, steroids, anti-D, these are first-line medications. Second-line medications, rituximab, splenectomy, thrombopoietin receptor agonists. Apart from this, there are danazol. There are so many medications that are available. But what is it that you should be doing? The most important in most of the patients who are presenting with asymptomatic or mild bleeding, observation, 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 and observation. Nothing else. Okay, so in a child, 70% of them, they present asymptomatic or mild bleeding. Just observe the child. Okay, the child is going to be doing well. Repeat a platelet count within a week. Most of the patients, even without treatment, by 4 to 5 days, they improve their platelet counts to more than 20,000. I do not say this, the UK guidelines do. Okay, so you can wait and watch in these patients, and there's no need for a treatment. So when to treat? If the platelet count is going to be less than 10,000, or if your practice guidelines say 20 or 30,000, depending upon which you follow, UK or Canadian Pediatrics Society, whichever it is. So have a platelet count less than X value, or if the child is having a bleed, okay, moderate amount of bleed, then treat them. So all the first line treatments are effective, IVIG, steroids, and your anti-D. But most of us use IVIG or steroids, isn't it so? IVIG in a dose of 0.8 to 1 gram per kg per day. Give it for 1 day. Second day, if the platelet counts are not improving, then you can repeat one more dose. It's by intravenous route, and the response is seen in 48 hours in 95%, raised to more than 20K. Okay. Steroids, prednisolone is preferred. 2 to 4 mg per kg per day, maximum of 120 mg daily. Give a short course of 7 days or less, not more than 7 days. This is very, very important. It's given orally, and by 3 to 4 days, you expect a response in 70 to 80%. So what do you see? Even with treatment also, it is going to be same 3 to 4 days, isn't it so? Only thing, the rate of rise will be more compared to that of not giving treatment. Okay, that is the only difference with treatment and without treatment. Without treatment, the platelet count rise might be slower, but with treatment, the platelet count rise is fast. It is faster with IVIG compared to that of steroids. So steroids are better than IVIG, or steroids are recommended to be used compared to IVIG in a child with ITP. Again, ASH 2019 guidelines. And short course of steroids are advised rather than longer course. Short course means less than or equal to 7 days. And prednisolone is the preferred steroid compared to that of dexamethasone. Dexamethasone, earlier it was used at 20 to 24 milligram per meter square, but now prednisolone is preferred compared to that of dexamethasone. Okay. IVIG, the one disadvantage with that is it is expensive compared to that of steroids, but the response time is faster. Okay. How do you manage a severe bleed? See, whenever there is a severe bleed or a life-threatening bleed, you try to control it in whatever way possible, isn't it so? You try to give steroids, you try to give immunoglobulin, you try to give everything to make sure this child does not bleed out and does not have a life-threatening bleed. Okay. So in a severe bleed, a IV steroid is indicated, like methylprednisolone. 30 mg per kg per day can be given for 3 to 4 days, along with IV immunoglobulin. Tranexaminic acid also can be added. And if the child is having a life-threatening bleed, platelet transfusion is indicated. Note that in a case of ITP with severe or life-threatening bleed, multiple platelets will be required, because whatever autoantibody is there is going to destroy both autologous and the transfused platelets at the same rate, isn't it so? So large volume of platelets might be required, and frequent monitoring of platelets, like as frequently as post transfusion, maybe 15 to 30 minutes later, you will have to do a repeat platelet count to see how this child is improving. So as frequently as that. And rest of the management will be similar to severe bleeding, plus your airway, breathing, circulation, all of those will come. All right. So this is in short about management. But how are you going to predict which child is going into a life-threatening bleed, or what are the risk factors? So if the platelet count is less than 20,000, if the child is having a mucosal bleed, a wet purpura is a good indicator that this child may go on to have a severe or a life-threatening bleed. A head trauma, exposure to any antiplatelet medications. These are all risk factors. Okay, so if these risk factors are there, keep the possibility of a severe or life-threatening bleed in this child's follow-up. So what happens if the child is not going to respond after a single dose of therapy? You may go for another first-line therapy. Say, for example, if you have given an IVIG first, go for a steroid next. Or the other way around, if you have given steroid first, go for an IVIG next. So if the child is going to not respond to any first-line therapy, you may consider a second-line therapy. And among second-line therapy, this is the order that is advised according to ASH 2019 guidelines. TPO receptor. TPO is thrombopoietin receptor agonist, L-thrombopag or romiplastin. First preferred compared to that of rituximab, and rituximab is preferred compared to that of splenectomy. Okay. Splenectomy only in 2 specific indications it is advised. A child who is more than 4 or 5 years with severe ITP, lasted more than 1 year, that is chronic ITP, and not controlled with medications, then you consider splenectomy. Or there is a life-threatening hemorrhage that is happening, and you feel that your medications and your transfusions may not be enough to bring the platelet count up to a level that is safe for the child, then splenectomy may be considered. Okay. So what are the complications that you expect with ITP? Now that we have completed the course of ITP and how you are going to manage, what are the complications that you expect? Or the worried complications are mainly intracranial hemorrhage. This we discussed is less than 1%. And severe bleeding is also less. It's less than 3%. How is the prognosis for a child who has had a ITP? As we discussed, a spontaneous resolution is expected in 70 to 80% by 6 months. Okay. So without treatment also, this child will have more than 20,000 platelets by 4 to 5 days, and by 6 months, most of them would have resolved. Relapse can be expected in 30% or 1/3 of the patients with ITP, 2 to 6 weeks post-treatment. How are you going to manage a relapse? Relapse, again, you should start from the beginning. Whether this child is having severe bleed, a moderate bleed, or no or minimal bleed. And depending upon that, you will manage this child. So take-home messages from ITP lecture are these. Presentation you should be very, very sure about, and no red flags should be there in this child. Lab investigation wise, you should know what are the red flags you should be looking for. CBC will have only thrombocytopenia and plus or minus mild anemia depending upon the bleed. Observation is the first line of therapy and not medication. Medication is only indicated for specific situations, and there is no need for routine bone marrow examination. And remember that this child will improve even without treatment. Only thing that will be required is observation and monitoring. And when in doubt, please always consult a hematologist, because we are not the experts. They are seeing more patients. So consult, and in concordance with what they suggest, go ahead and manage a case who's more complicated. So these are my references, UK guidelines. I forgot to update in this. So thank you guys for your patient listening, and special thanks once again to Dr. Raghuram sir for helping me out, you know, giving this presentation good, how to tell, roundup. Yeah. Thank you, sir. Thank you, guys. Please subscribe, share among your peer group and academic group so we can all learn pediatrics together. If I have made some mistakes or if I have missed out some important points, I'll definitely update in the description box below. Bye bye. Take care and all the best.